In our previous PowerPoint, we reviewed how breathing is regulated, and that's predominantly while we're awake. So in this PowerPoint, we're going to look how breathing is regulated or affected by sleep. Let's go on to our next slide. Breathing in sleep. As we fall asleep, the muscles in our body are going to relax. We're going to breathe more shallow, or our tidal volume is going to be smaller. We breathe slower, or we're going to have a slower respiratory rate. Our breathing continues to be rhythmic in most of our stages of sleep, and then our heart rate slows and our rhythm is very stable in most stages of sleep. And we call that non-REM. In our non-REM stages of sleep, our breathing is very rhythmic, our heart rate is very stable and slow, we breathe more shallow, our body's just nice and relaxed. Now when we go into REM sleep, or rapid eye movement sleep, our breathing and heart rate are going to change a little bit. Our breathing is less regulated, so occasionally we may take some deeper breaths. Breathing can be erratic at times, and it can increase in rate at times. Our heart rate is less regulated as well, and so our heart rhythm can be slightly erratic. Let's go on to our next slide. So we noticed that in REM, our breathing and heart rate become a little erratic as compared to non-REM, where everything is very stable. If anything, it's a little shallow or slower than compared to when we're awake, but as compared to REM, our breathing and heart rate become a little erratic. So why does this happen? Why does it change with the different stages of sleep? Well, in REM sleep, our major muscle groups are inhibited. We like to say that they're paralyzed during sleep. So we lose our accessory muscle use, which helps with those breathing. Our breathing patterns and our heart rate coincide with rapid eye movements. So as we see the rapid eye movements occur, you'll also notice that that's when the heart rate and respiratory rate will change. They'll become erratic. You may see the respiratory rate increase or become have to take a few deeper breaths, and the heart rate may become erratic as well. The diaphragm and heart are the only major muscles that are not paralyzed or inhibited during REM sleep. So they're the ones with the most control during this time. Nothing concrete explains the cause of rapid eye movements and why or how the heart rate and respiratory rate become so erratic during that stage of sleep, but it's known that respiratory rate and heart rate do change during REM sleep, that they do become less regular, so to speak. Let's go on to our next slide. Control of breathing and sleep. While we sleep, our breathing is regulated predominantly by changes in our CO2. When we're awake, the body responds to changes in CO2 the quickest and greatest. So if our CO2 goes up, we very quickly change our breathing and our cardiovascular system adjusts to that change. In non-REM sleep, the body responds the slowest to changes in CO2, and the least amount of this occurs in non-REM, or what we call quiet sleep. So what happens if we're not responding to these changes as quickly as when we're awake, what happens then is that our CO2 levels become slightly higher in non-REM sleep as compared to when we're awake. The slow response to CO2 changes and slightly higher CO2 levels in non-REM sleep may explain why we often stop breathing for about 10 seconds as we fall asleep, transitioning from wake to non-REM. We call this central apneas because we see that as we start to doze off and fall asleep, no airflow moves through the nose or mouth, and the respiratory muscles don't even attempt to take a breath. And that happens, it lasts for about 10 seconds as we doze off, and we call that a central apnea, and that is very common and considered normal to occur as we fall asleep. And again, they believe it's because we are less sensitive to the CO2 changes as we drift off to sleep. Now in REM sleep, our response to CO2 is somewhere in between that of being awake and our non-REM sleep. So our sensitivities to CO2 changes is least effective in non-REM sleep, slightly more effective in REM, and the most effective while we're awake. Let's go on to our next slide. Gas exchange in sleep. In normal sleep, our minute ventilation is reduced by about 1.5 liters. Our PaO2 decreases by about 10 torr. and our PaCO2 increases by about 8 torr. These are all due to the decrease in tidal volumes and decreased CO2 sensitivity and decreased respiratory rate, which occurs during non-REM sleep. We also see a decreased FRC, or functional residual capacity. We believe this is primarily due to laying down, the compression of the thorax by the body weight, and our loss of muscle tone once we fall asleep causes us to lose some of our functional residual capacity. If it's significant enough, it can cause atelectasis, leading to VQ mismatching. So let's go on to our next slide. Hypoventilation in sleep. This can be caused by many factors. Couldn't be due to increased upper airway resistance. This can occur due to the loss of muscle tone in the upper airway muscles. Can also be due to excessive weight in the upper airway. Abnormally structured airway leading to decreased diameter of the airway, especially once those muscles relax. This would also cause an abnormal increase in hypoventilation. So we'd end up with a higher CO2 with increased upper airway resistance, or it's harder for air to get down to the lungs. This can cause an increase in CO2 or worsening hypoventilation. Another thing that occurs during sleep is there's a decrease in our basal metabolic rate. This normally occurs to some extent in everyone. And then we also have a reduced central respiratory drive. And this is due to our loss of our wakeful stimuli. This is much worse in REM, due to an even more decrease in the central respiratory drive than any other stage of sleep, and due to the absence of accessory muscle use. So all of those play a role in why our central respiratory drive is reduced. Let's go on to our next slide. Okay, work of breathing in sleep. I have stated on this slide work of breathing is increased during sleep. I don't know that that's exactly true. I think a better way to say that is work of breathing can be affected during sleep due to special conditions. So let's take a look at a couple of those. First of all, bronchoconstriction. Bronchoconstriction is likely to occur during sleep due to several factors. For one, we have an increase in vagal tone when we fall asleep. And when we talk about vagal tone, this refers to parasympathetic system activity. And if you remember about your parasympathetic system, when it's activated, it causes the heart rate to slow down, and it causes the bronchial smooth muscle to be more prone to bronchoconstriction. So because of an increase in vagal tone, if someone happens to experience bronchoconstriction, it's more likely to occur when they go to sleep for this reason. Another one is circulating histamine. When we sleep, histamine is blocked from attaching to the histamine receptor. This allows more histamine to circulate throughout the body, and histamine is known to cause bronchoconstriction in certain individuals. So with more histamine circulating around, people who result in bronchoconstriction in response to histamine are more likely to do so. Another cause of bronchoconstriction during sleep is decreased cortisol. Cortisol is one of our body's naturally occurring hormones. It's actually a steroid, and so it's responsible for keeping inflammation away. At night, our cortisol levels drop to its lowest, and so we have less of that regulating or keeping our inflammation under control. So inflammation can increase, which also can lead to bronchoconstriction. Another one is airway cooling. This is simply a result of temperatures dropping at night. In select individuals, this can trigger a bronchoconstriction reaction. And then late response to allergens. Some people who have asthma, they can have an early response, which is an immediate response to an allergen, and other individuals have what's called a late response, and that can occur like up to 8 hours after they've been exposed to an allergen. So if someone was out playing soccer during the day and they go to sleep at night, that late response is going to kick in the middle of the night. Unfortunately, during this time, they also have a decrease in cortisol levels, so their body can't keep that inflammation under control. And then you have an increase in histamine circulating through the body, and increased vagal tone, and all of these set that person up for a bronchoconstriction event in the middle of the night. Another problem that can cause bronchoconstriction is GERD, or gastroesophageal reflux disease. I've heard of a lot of people being treated for asthma over and over unsuccessfully when really it's gastroesophageal reflux disease occurring. And this is more apt to happen at night while we're sleeping because we have a reduced cough reflex, and we're laying flat. So you lay flat, your body regurgitates a little acid. You can't cough because you're asleep. That acid causes inflammation in your airways. Your body's response to inflammation is bronchoconstriction, and so you wake up with nocturnal asthma symptoms or wheezing and coughing, and they sometimes can miss that diagnosis. And then another contributing factor is while we're sleeping, we have reduced mucociliary transport. Remember, the mucociliary blanket in our lungs is responsible for helping keep debris and microorganisms from getting deep into our lungs and causing a pneumonia. So if this is reduced during sleep, it can also cause an increased work of breathing during our sleep. Okay, that concludes this PowerPoint.